Welcome to Chapter 16, Disorders of Childhood and Adolescence. In this chapter, we will discuss psychological disorders occurring in childhood and adolescence. Looking at our overview, we will do a brief overview of childhood and adolescent disorders. We will then dive into internalizing disorders, externalizing disorders, elimination disorders, and neurodevelopmental disorders. And we will end with a discussion about contemporary trends and future directions. An overview of child and adolescent disorders. Approximately 22% of the children in the United States suffer from a serious emotional or behavioral problem. Anxiety disorders are the most common types of disorders for children and adolescents. Accurate assessment of mental disorders involves clinicians considering the child's age and developmental level, as well as environmental factors, and asking questions such as, is the child's behavior significantly different from that of other children of the same age? Are the symptoms likely to subside as the child matures? Are the behaviors present in most contexts or only in a particular setting? For example, are the behaviors only present at home and not present at school or other settings? And are the symptoms occurring because adults are expecting too much or too little of the child? Clinicians are very cautious when making a diagnosis and weigh the effects of labeling a child on future development against the knowledge that untreated disorders can result in ongoing mental distress. The lifetime prevalence of psychiatric disorders in youth ages 13 to 18. You will find this table 16.1 on page 505. You see that generalized anxiety disorder affects females at a rate twice as frequently as males. And you also may notice that depression and bipolar disorder impact with severe impairment the highest percentage of children and adolescents. And this is likely related to the symptoms associated with these disorders having more significant impairment on the child's functioning. Before we look at the individual disorders, we'll quickly revisit risk factors, protective factors, and resiliency for children and adolescents. As we have been talking about, stressful events, ongoing stress, abuse, and trauma is a significant risk factor for many different mental health disorders. You'll also see listed here that substance misuse is a risk factor, that parental substance use would also fall into this category of being a risk factor, medical conditions or physical health conditions, history of a traumatic brain injury, lack of appropriate family or social support, and learned behavior. So that might be any behavior that would be modeled by an adult or a caregiver that would be less healthy ways of coping that then becomes a risk factor for that child or adolescent. Some protective factors for children and adolescents. A few key protective factors from this list include feeling a sense of control over their own life and the choices that they make, in addition to the biggest protective factor, which is feeling close to at least one healthy adult. And that adult doesn't necessarily have to be their primary caregiver or a parental figure. If they feel close to at least one healthy adult, that is shown to be a huge protective factor in increasing resilience and positive outcomes for adolescents. Resiliency. We've talked about resiliency throughout this class, but a quick recap, that resiliency is about the ability to bounce back from adversity. And the APA provides these recommendations for fostering resiliency in youth. I won't read through the whole list, but this is just something for you to be able to read through on your own and refer back to as needed. Internalizing disorders among youth. Disorders involving emotional symptoms that are directed inward are referred to as internalizing disorders. Anxiety and depressive disorders are among the most common internalizing disorders, and research has shown that anxiety and depressive disorders often lead to substance use and misuse and suicidal ideation or suicide attempts. As we talked about earlier in class, the mental health symptom often comes prior to that experimentation with substances or that substance use, which then is used as a method to try to cope with any of those unwanted symptoms that might be associated with anxiety or depression, or to self-medicate for those symptoms of anxiety and depression, especially in youth. Our text notes that certain behavior patterns among youth with internalizing disorders, such as abrupt changes in behavior or self-destructive behavior, can signal the need for further assessment in order to rule out any potential sexual abuse, as that would significantly impact the course of treatment for that youth. Most common mental health disorder in childhood and adolescence is anxiety. Anxiety disorders are characterized by a significant level of discomfort or fear when facing unfamiliar situations and can significantly impact academic and social functioning. The two types of anxiety disorders that we're going to take a closer look at that fall into that category of internalizing disorders are separation anxiety and selective mutism. Separation anxiety is characterized by severe distress or worry about leaving home or being away from their primary attachment figure. And selective mutism is characterized by a consistent failure to speak in certain social situations. It would be very common for a kiddo with selective mutism to only speak at home when immediate family is present. They may not even speak at home when close friends are around or when that second degree family is around, like aunts and uncles, grandparents, and it oftentimes gets in the way of academic performance because of not engaging with educators and not speaking in the school setting. We're also going to take a look at attachment disorders. Infants and children raised in stressful environments that lack predictable parenting and nurturing sometimes demonstrate significant difficulties with emotional attachments and social relationships. Two types of attachment disorders that we're going to take a closer look at are reactive attachment disorder and disinhibited social engagement disorder. Reactive attachment disorder is characterized by inhibited, avoidant social behaviors and a reluctance to seek or respond to attention or nurturing. So there's two pieces to this. There is a reluctance to engage or seek comforting from an attachment figure when the child is distressed, and there is a lack of response to any offering of comforting from an attachment figure when that's provided in response to potential distress from that child. And then disinhibited social engagement disorder is an attachment disorder characterized by indiscriminate, superficial attachments and deseparation from interpersonal contact. Something that would be really common to see with a reactive attachment disorder, let's say you maybe have an adolescent who has experienced some significant distress in lack of predictable parenting or maybe abandonment from a parent, a key caregiver figure that has left and only intermittently engaged with them throughout their early childhood and early adolescence. When that individual is experiencing a stressful situation, and it doesn't even have to be extreme distress, they may shut down. And even if they're in a setting with a lot of healthy, nurturing, and caring adults, it might be likely for them to kind of turn their back to them and look away and get really quiet and not engage. And even when one of those healthy adults who has a healthy relationship with this adolescent might reach out to offer a cue of safety or might reach out to comfort that adolescent, they oftentimes may not respond to that cue of safety or to that comfort offered by that healthy adult. Post-traumatic stress disorder in early life. The effects of trauma and resultant post-traumatic stress disorder can be particularly distressing in childhood. We watched that video about ACEs earlier this week, and we're going to take a quick look here about quick look at developmental trauma disorder. So in 2009, professionals researching and treating complex trauma in children proposed a new diagnosis for the DSM-5. This diagnosis did not end up being included in the DSM-5. However, it was the first time that a diagnosis like this was as close to being included as it was. And these providers really, and these clinicians really said that lots of children have been diagnosed with unrelated disorders. However, that at the core of the disorders, it really was this piece about developmental trauma that needed to be treated. And some of the disorders that they said these kiddos were being diagnosed with were some of the disorders that we're going to talk about in this chapter. Non-suicidal fact or fiction. We are going to engage in a brief activity in class this week about fact or fiction, kind of debunking some myths around non-suicidal self-injury. And non-suicidal self-injury involves intentionally inflicted superficial wounds. The pain induces a temporary sense of calm and well-being. There's can be intense negative thoughts or emotions and a preoccupation with engaging in self-harm. And in the DSM-5, non-suicidal self-injury is a category under study for diagnosis, and it oftentimes appears as a symptom to other disorders that we see in children and adolescents. When somebody is engaging in non-suicidal self-injury, they might cut, burn, stab, or hit themselves. There are also other types of behaviors that adolescents might engage in that also would fall into that category of non-suicidal self-injury, and we'll explore that a little bit more in our fact and fiction exercise. Mood disorders in early life. Depressive disorders among young people are most prevalent among females and older adolescents. Environmental factors are a frequent cause of depression in childhood, whereas genetic and other biological factors exert more of an influence during adolescence. Children are especially vulnerable to environmental factors because they lack the maturity and the skill to deal with stressors in the same way that adults have capacity to deal with that. We are going to look at disruptive mood dysregulation disorder, which is characterized by chronic irritability and severe mood dysregulation. This diagnosis is not made in children younger than 6 and often predicts development of depressive or anxiety disorders later in life. An example of a kiddo who is experiencing disruptive mood dysregulation disorder would be a young child who is described as being irritable and difficult to please. Temper tantrums, often involving attempts to hit his parents, occur multiple times a day. And later on in life, in later childhood, that child is still frequently labeled as grumpy and has frequent temper outbursts in many settings. That individual may meet criteria for disruptive mood dysregulation disorder. Pediatric bipolar disorder. This is characterized by mood variability, both depressive episodes and departure from typical functioning that characterize adult bipolar disorder. There is elevated neurological responsiveness to emotional stimuli, and various brain abnormalities have been found. There is a note here that pediatric bipolar disorder may be overdiagnosed. There is concern that this disorder might be used more frequently than it actually fits to be used, and that the introduction of the disruptive mood dysregulation disorder may help in limiting that overdiagnosing of pediatric bipolar disorder. With pediatric bipolar disorder, you really have to see that significant mood variability from the manic episodes or hypomanic episodes alternating with the depressive and irritable episodes. And sometimes there's concern that this disorder is used even when the child does not meet that full criteria for the manic and hypomanic episodes. And oftentimes, with high rates of the pediatric bipolar disorder diagnosis, that bipolar disorder diagnosis does not always then present as bipolar disorder in adult life. And so it is important to be very careful about not overdiagnosing as it relates specifically to this disorder. Disruptive mood dysregulation disorder and pediatric bipolar disorder. This is table 16.2 from our text on page 511. Just have this in here for your review and will be a helpful piece for you to use as you're preparing for the next exam. We're now going to take a look at externalizing disorders, disruptive impulse control, and conduct disorders. Oftentimes, these externalizing disorders have a higher likelihood of resulting in negative parent-child interaction, high family stress, and negative feelings about parenting. There is discussion in the DSM-5 with some of these disorders that the behaviors, the adolescent behaviors or child behaviors, then lead to increased stress for parents, and that shifts the parent's behavior, which then continues and perpetuates this negative behavior pattern between the parent and the child. And it is hard often to determine which causes which, but they certainly both add fuel to the fire in these really high, very stressful family situations. We are going to take a look at a few different kinds of externalizing disorders, but it is important to remember that early intervention can help interrupt those negative cycles and those negative behavior patterns. And diagnosing that these disorders is really controversial. It's difficult to distinguish these disorders at times from normal defiance and noncompliance. And then there's oftentimes the relational piece as it relates to caregiver child or parent child and how those interactions continue to influence these behavior patterns. Oppositional defiant disorder is characterized by a pattern of negativistic, argumentative, and hostile behavior. It would be common to see loss of temper, arguments. Primarily, it is directed toward parents, teachers, or other individuals in authority, but there's no serious violation of societal norms with oppositional defiant disorder, or ODD. Symptoms often resolve, especially with effective intervention. Intermittent explosive disorder is prevalent, persistent, and seriously impairing disorder. It involves recurrent outbursts of verbal or physical aggression, and the frequency is at least twice a week for at least 3 months, or 3 outbursts per year that result in injury or property damage. While the prognosis for ODD is, especially with early intervention, is pretty good, ODD from our previous slide can evolve into a conduct disorder or a depressive disorder. And with intermittent explosive disorder, it also can resolve with effective intervention, or it could evolve into increased concerns with anger in adulthood. And next we have conduct disorder. Conduct disorder is characterized by aggression or cruelty to people or animals. It is also characterized by destruction of property, stealing, rule violations, and the behaviors must continue for at least 12 months to meet the criteria for conduct disorder. Individuals with conduct disorder often exhibit limited pro-social emotions. So that would be an individual that does not show much guilt, does not show much remorse, and also has a limited capacity for empathy. As compared to some of the other externalizing disorders and some other childhood disorders such as ADHD, conduct disorder has the poorest prognosis, and it is highly correlated with leading to criminal behaviors or other antisocial acts in adulthood, and at times also antisocial personality disorder later in life. Here we have the table 16.3 from our text. Again, refer back to this as you're completing your study guide and preparing for exam 2. Etiology of externalizing disorders. So we're looking at the potential cause for these externalizing disorders. We see that we look at the biological, psychological, social, and sociocultural dimension, poverty, male gender, childhood maltreatment, limited fear response, oppositional temperament. All of those are some of the things that fall into that potential cause for externalizing disorders. And a key here is to note that family and social context play a large role in externalizing disorder development, and also play a large role in how that pattern continues to persist in families, and how that then strengthens or eliminates behaviors. Treatment for externalizing disorders, interventions that address family and social contexts, and psychosocial skills. So one of the strategies that I use frequently for adolescents who are struggling with difficult behaviors and maybe meet criteria for some of these externalizing disorders is oftentimes family therapy. And a brief intervention type of family therapy that I use is functional family therapy, and we really work to target those behavior patterns and to work to make some strategic interventions and modifications to those behavior patterns, things that the adolescents do and things that the adults do that will work as it relates to their relational functions, but that help to eliminate some of those undesired behaviors and help to create healthier family relational patterns. And next we're going to move into elimination disorders. We'll first take a quick look at enuresis, which involves periodic voiding of urine during the day or night into clothes, bed, or the floor. Most often this is involuntary, although at times it may be intentional. And a quick look at encopresis, which is defecation onto clothes, floor, or other inappropriate places. A kiddo must be at least 4 years old and have defecated inappropriately at least once a month for 3 months or more in order to meet criteria for this diagnosis. Our last set of disorders that we're going to look at today is neurodevelopmental disorders. which involve impaired development of the brain and central nervous system. Symptoms become increasingly evident as the child grows and develops. The different types of disorders of neurodevelopmental disorders we will cover in this chapter include tic disorders, ADHD, autism spectrum disorders, and intellectual and learning disorders. Tics are recurrent, sudden, involuntary, non-rhythmic motor movements or vocalizations. An example of a motor tic might be blinking, or maybe squishing your nose, or puckering your lips, and an example of a vocal tip might be clearing your throat, or coughing, or engaging in repetitive vocalization of particular words. Oftentimes, short-term suppression of a tic is possible and results in subsequent increases in the tic. The tension may build prior to the tic, followed by a sense of relief after the tic occurs. Symptoms often tend to peak prior to puberty, and symptoms are often temporary and may disappear without treatment, especially when the symptoms initially present in early childhood. Tourette's disorder. Tourette's disorder is characterized by multiple motor tics and one or more vocal tic, and these have to be present for at least 1 year. Coprolalia is a characteristic of Tourette's disorder, and it is involuntary uttering of obscenities or inappropriate remarks, and is present in only 10% of those individuals with a diagnosis of Tourette's disorder. We're going to take a look at attention deficit hyperactivity disorder, or ADHD. This is characterized by inattention and/or hyperactivity and impulsivity. Symptoms begin before the age of 12 and persist for at least 6 months. Symptoms oftentimes interfere with social, academic, or occupational activities, and it is important for the individual to display these symptoms in at least 2 different settings. And so if the symptoms were only present in school, the kiddo would not meet criteria for ADHD, but if the symptoms are present in school and at home, and there's struggle with that inattention and or hyperactivity in both of those settings, then the kiddo would be more likely to meet that criteria for ADHD. ADHD is the most frequently diagnosed disorder in preschool and school-age children. Characteristics of ADHD: fidgeting, restlessness, excessive movement, talking, blurting, distractibility, difficulty with focus, difficulty paying attention and staying organized. All of those symptoms are characteristics of ADHD, and this chart nicely lays them out in the categories of inattention and the categories of hyperactivity and impulsivity. Etiology, so the cause of ADHD, looking at the biological dimension, the psychological, social, and sociocultural dimension. Again, we see that risk factor of social adversity, family stress, and early life experiences, and how that is a potential cause of ADHD. And from the biological dimension, it is highly heritable, with up to 80% of symptoms explainable by genetic factors, but the exact nature of that is still unclear. And there are some hypotheses about neurological mechanisms as it relates to abnormalities in the prefrontal cortex, brain structure and circuitry irregularities in the frontal cortex, cerebellum, and parietal lobes, and reduction in neurotransmitters, all as potential biological factors for the cause of ADHD. Treatment of ADHD. Stimulants such as Ritalin have been used for a long time, decades, to treat ADHD. It helps to normalize that neurotransmitter function, which we saw on that previous slide as a cause of ADHD. 30% of youth do not respond to treatment using stimulants for ADHD, or they experience significant side effects. It is still considered the first-line treatment approach, and likelihood of medication use greatest for those with the most severe symptom and most significant functional impact. We're going to take a look at autism spectrum disorder. Autism spectrum disorders are characterized by significant impairment in social communication skills. Symptoms range on a large range from mild to severe. Autism spectrum disorders occur 5 times more frequently in boys than in girls, and the prevalence has increased over 120% between 2002 and 2010. This might be attributed to increased awareness and other possible unknown influences as it relates to the increased prevalence rate. Symptoms of ASD include deficits in social communication and social interaction. Oftentimes, there is a lack to engage in typical social cues. And we also may see repetitive behavior or restricted interests or activities involving at least 2 of the following: repetitive speech, movement, or use of objects, intense focus on rituals or routines, or strong resistance to change. So transitions are oftentimes very difficult if they're not very structured. Intense fixations or restricted interests, and atypical sensory reactivity. And that sensory piece is a key piece for autism spectrum disorders, and also typically a key piece in treatment for autism spectrum disorders. As it relates to the repetitive speech, movement, or use of objects for the symptoms for ASD, echolalia is a frequent symptom or a common symptom that we may see with ASD, and that is the repetition of vocalizations made by another person. And so one person might make a comment about making chocolate chip pancakes, and the individual with ASD may repeat something about chocolate chip pancakes in their next phrase. Other facts about autism spectrum disorders, ASD. For some, a period of relatively normal development precedes ASD symptoms. It is not diagnosed before the age of 4. ASD is highly linked with declining eye gaze beginning from a really young age, about the age of 2 months, which is an encouraging sign as it relates to potential early diagnosis and early intervention. Intense early intervention has reversed progression and eliminated the disorder in some children. And that would likely be a pretty significant and intense intervention that is used really consistently in order to potentially reverse any progression of the disorder. Etiology, the cause of autism spectrum disorder. A great deal of research has been focused on the cause and potential causes of ASD, with the hopes in being able to notice the signs and symptoms sooner and provide earlier intervention because of that piece that we talked about in that last slide. So because some intense early intervention has been shown to reverse the progression. And in looking at the potential cause for ASD, biological factors do seem to play the most critical role. So there's a strong genetic influence, and ASD is linked with neurological findings, unique patterns of metabolic brain activity, reduced gaze toward iris regions of faces, high serotonin levels, and accelerated growth of the amygdala. Recent research findings show that careful analysis of postmortem brains of children with ASD found patchy areas of disrupted neuronal development, which suggests that brain abnormalities begin during pregnancy in the normal cell layering process. And children with ASD metabolize environmental toxins differently. So lots of really interesting research findings coming out about potential etiology of ASD and how that will influence our early detection and early intervention with this disorder. Other potential influences on cause of ASD include early psychological theories as it relates to parent-child interactions. Behavioral characteristics and caretaking demands associated with ASD can cause family stress, and oftentimes children with ASD may feel isolated, and parents of children with ASD may be emotionally impacted because of that child's limited ability to engage in reciprocal social and emotional relationships. ASD intervention and treatment. Prognosis is mixed. Individuals with milder symptoms may be self-sufficient and successfully employed later in life, and significant recovery is linked with intense early intervention. We're only going to take a quick look at intellectual disability, Down syndrome, and learning disabilities in this PowerPoint. Intellectual disability was formerly referred to as mental retardation and is characterized by limitations in intellectual functioning and adaptive behaviors. It ranges from 4 distinct categories. Down syndrome is the most common and most easily recognized chromosomal disorder resulting in intellectual disability. In the vast majority of cases, an extra copy of chromosome 21 originates during development of neurological characteristics, and there are neurological characteristics associated with this disorder. Psychological, social, and sociocultural dimensions. The genetic background interacts with environmental factors. Strong positive influences, encouraging consistent routines in the home environment, and ongoing education and intervention for both intellectual disability and Down syndrome. And learning disorders are characterized, it's an academic disability which is characterized by reading, math, or writing skills deficits, and primarily interferes with academic achievement and daily functioning as it relates to those specific skills. Occurs twice as frequently in boys than as in girls. Support for individuals with neurodevelopmental disorders. The goal for these interventions is to build skills and develop potential to the fullest. And for those with moderate to severe intellectual disabilities or autism spectrum disorders, support often begins in infancy and extends across the entire lifespan. Support in childhood. So, individual home-based or school-based programs, especially with parental involvement, are a key part of early intervention and positive outcomes later in life. School services individualized to meet the needs of the child in order to maximize learning opportunities. Institutionalization with these disorders that we were just talking about is really rare. Many adults live with family members or caregivers if living independently is not an option, but it is always encouraged to have the individual in the least restrictive environment as possible in order to promote independence and to promote as much personal choice and privacy as possible. We have made it to the end of Chapter 16. A quick review of contemporary trends and future research. The root of many adult mental disorders lies in a stressful childhood. We started this unit even before diving into this lecture in the discussion about adverse childhood experiences, and we are coming full circle, ending ending in that same place, identifying that the root of many adult mental disorders lies in a stressful childhood. This speaks to the importance of prevention programs, of evidence-based interventions and early intervention, and research to address long-term risks and benefits of various interventions. The reflection and review questions. Take a look at these questions, jot down some notes on your study guide, and I look forward to seeing you all in class again. We'll get back to that non-suicidal self-injury activity, and I will see you all soon. Take care.